Annual Dialysis Conference, presented by the Carl Nolf, MD, Division of Nephrology.
Welcome, everyone. My name is Encore. I am a nephrologist at the Warren Alpert Medical School at Brown University and a fervent home dialysis advocate. And so today I am going to be leading our webinar, and we'll be talking about choice of vascular access in home hemo. And there we go. So we're going to start with just a bit of an agenda. So our agenda, which is building off of a phrase that came up during the last webinar, which I really loved, which was we need to move from fistula first to patient first. We're going to talk about the tensions behind fistula first and patient first, talk about where the system is, give a little bit of a risk benefit, and approach this more from an ethical lens. So we're going to talk about risks and benefits of CVCs and AV access. We're going to talk about the ethics of this, review data, and provide a framework for patient-centered shared decision-making, which is where I hope we end up. So hopefully we're all familiar with this, but for those who aren't, HHD offers a lot of benefits, including greater flexibility, control over your treatment schedule, improved clinical outcomes. It empowers patients to take an active role in their own care. And the choice of vascular access is one of the most critical decisions and, in my opinion, one of the greatest barriers in the HHD journey. I think that we can do a lot of great things to empower patients to self-cannulate, but the need to self-cannulate is one of the greater barriers to home hemo. And so when I think of home hemo, I think of the clinical benefits, but I also think of it as a way to empower patients, provide them flexibility, bring them self-care. And when I think of empowering individuals, bringing them flexibility and self-care, what I think of is respecting their wishes. What I don't think of is the paternalism that underlies a lot of medicine. And so we have a dilemma here because, as you kind of can tell from where the discussion is going and familiarity with vascular access literature, there are tensions here. And so the central dilemma to me is one between autonomy and non-maleficence. So from autonomy, the patient has a right to self-determination. They should be able to make informed decisions about their own body and care based off their values and preferences. Patients should not be coerced into a vascular access choice of our choice. They should be given the opportunity to make their own choice. But we also have a duty to, quote, do no harm, and that involves recommending treatments that minimize risk and maximize clinical benefit. And you can flip these things around. You could talk about autonomy as a physician. We have autonomy to make the decisions that we believe are best and to guide our patients as we believe best. And so there are a lot of tensions here between a patient's autonomy, our non-maleficence, our own autonomy. That did a little fancy transition move. And these are added to not just between the patient and physician, but then also through our healthcare system. Vascular access measures include catheter use. So the ESRD Quality Incentive Program, which is a program that is kind of like one of the early value-based care models, very little bit of the value. It can trigger up to 2% Medicare payment reduction, but it is still one of the earliest Medicare value-based care models and one of the earlier value-based care models of dialysis. Penalizes facilities for higher rates of CVCs. And so if you have a lower catheter performance, you get a lower total performance score, and that can trigger a 2% Medicare payment reduction, but not a payment reduction to just that patient, but to all of your Medicare patients in your ESRD facility. So all your in-center hemo, all your PD patients. And so this tension escalates. We have a tension between a patient, a provider, and now the system. And so I am very, very bad at figures. I tried to use AI to make this. As you can see, AI is not the best at making things because it couldn't spell expert, but it was the best I could do. So I guess a lesson in overutilization of AI. I spent way too long on this slide. But in terms of shared decision-making, you get a balancing act. I think what I would like to view as shared decision-making is that a patient's expertise, their life and goals, meld with my medical knowledge and my expertise, and the best decision comes of those. And that's where I hope to get to. But what we actually have right now is the patient's expertise, the clinician's expertise, and then policy that give you the actual decision. So we do have shared decision-making. It's between me, my patient, and Centers for Medicare and Medicaid Services. So let's talk about those tensions more. The case for the catheter. So there are kind of clear reasons that patients would want a catheter. There are no needles. You direct correctly to the catheter lumen. This is great for people with needle phobia. Also great for people who are concerned about exsanguination, which, while exceedingly rare, the worry over it is not exceedingly rare. The actual event is extremely rare, but the worry isn't. And from a patient perspective, it's less invasive, it's less intimidating. There are patients who I am fairly certain, because I've taken care of them, who would say I'm willing to take the risk of bloodstream infections to not do this. Of course, the risk of bloodstream infections is non-subtle, and there's a price that comes with the catheter. If you look at the NHSN dialysis event surveillance report, the bar in the middle is not subtle. Your rate of BSIs per 100 patient months by a vascular access type is 0.26 for fistulas, 0.39 for grafts, 2.1 for CVCs. Anytime you see a bar chart like that, it's not subtle. But it quantifies what we all know, which is that risk of a catheter. There are lifestyle impacts of a catheter, and so you'll have patients who are pro-catheter, you'll have patients who, when educated, are not pro-catheter at all. Bathing and showering is a major limitation. It needs to be kept dry. We actually recommend that our patients will sponge bath if they have a catheter, so a lot of patients don't like that. Swimming is a major limitation if you have a catheter. Body image. Body image is an interesting one, because you can make an argument for body image for a catheter or for a fistula. For the catheter, the external lumens can be a reminder of the illness. It can be cosmetically unappealing. It's quite visible through a t-shirt. You could see the lump through a t-shirt. And so a lot of patients will view the CVC as a negative in terms of body image. Others will say you can't really see it, but you can see the fistula, and the fistula is forever. So body image is, like many things, very individualized, while our system is not. And then dependence, the meticulous care, dressing changes, that I'll call it a tie, because you still have to be meticulous with your fistula. Of course, the case for an AV access is non-subtle, entirely under your skin, creating a natural barrier to infection. I showed you that infection risk earlier. It is significantly lower. There's superior longevity. An AV fistula, when it's mature, can last years, decades. I've had patients who have using the same fistula for 20 plus years. Grafts typically last fewer, and then catheters even fewer, although some patients can persist with the long-term catheter, particularly some of your home hemo patients who typically will have a lower blood flow rate. So that last part, you could get a higher blood flow rate out of a fistula, but probably not one that you actually need for your patients, particularly some of your nocturnal home hemo patients who could run a very slow blood flow rate because they have all the time in the world on dialysis. The challenge of an AV access, again, non-subtle. I don't think I need to tell you. Pain is the biggest one. Patients do not like cannulating. They do not like getting cannulated, and it's because you're sticking needles. Patients who have experience with buttonholes will, by and large, tell you they are significantly better from a pain perspective. Studies haven't really panned that out, but I can tell you from a patient perspective, patients find a huge difference. Bleeding, of course, and then stress. The stress of the fistula, the stress of, is there something that I could do to rupture it, having an aneurysm bleeds, are all sorts of things that are worrisome to patients. So to summarize, if you look at a fistula versus a catheter, and I also have graphs in the middle, there are a lot of differences. Your fistula has the fistula has the lowest infection risk, the catheter the highest. Longevity for a catheter is low, for a fistula is excellent. Could use a catheter immediately. It takes a while to use a fistula. Catheters could go in immediately. They don't need needles, but survival is the lowest. But a lot of the data that I'm sharing with you comes from in-center patients. And so HHD maybe changes the risk profile. We need more evidence on this. There was some interesting abstracts presented at Kidney Week, but still more detail needs to come out. There are things that can change that risk profile. When you're dialyzing at home, you have a single cannulator. You have no time constraint pressure. In a dialysis unit, they are moving from patient to patient to patient. You also don't go to a dialysis unit thrice weekly where you get cohorted with a lot of pathogens. And nobody cares about themselves as much as the person themselves. So you have ownership over cannulation. That too we oft compare, HHD with the catheter to HHD with the fistula. And I think that when data comes out, we will find that HHD with the fistula is better than HHD with the catheter. But is that really the right comparator? My patient who does not want a fistula is not often saying like, oh, I'm debating between HHD with a catheter or a fistula. They want to be with a catheter. And so maybe the real comparator is in-center hemo with a catheter. And so that might be where we should be comparing our risk. And as we compare our risk, we should again go back to what patients care about. And this is what patients care about. And this is from the Song HD study, which is a group that's coming together to put together core outcomes and critically important elements to stakeholder groups. And yes, mortality is absolutely one of them in section 1. And you could argue catheters are associated with mortality. Vascular access is also one of them. But vascular access varies by the patient, by the group, by physicians, by patients. And as you can see here, even though it is in that core section 1, there's a lot here. If you go beyond that section 1, you have dialysis-free time, hospitalizations, family and friends, infections, immunity, target weights, feeling washed out, ability to travel, ability to work, financial impacts, food enjoyment. There is a whole world beyond just vascular access. And you will have patients who say, I want the most durable vascular access for the longest survival. You'll also have patients who say that of all the things listed here, there are other ones that are higher on my own personal priority list. And for those patients, fistula might not be first. And so we have an ethical collision point. So your patient might want to choose a catheter. You, as a clinician, might feel that moral and fiscal discomfort. Then you might try to force them to do a fistula, which violates their agency. Both choices are defensible. Their choice to choose a catheter is defensible. Your own moral discomfort is defensible as well. So essentially, we're at a point where I think that fiscal discomfort has forced us to be at odds with each other. And so let's share this in a couple of cases that are reflected through the lens of the ethics of what we're doing. So this is Mr. L. He's 58. He wants to start HHD immediately. He's CKD5. And he wants to start with a catheter. He wants to defer a fistula. He doesn't want a fistula at all. You counsel him on a fistula, but he needs dialysis. You start him on dialysis with a catheter. 3 months later, he gets bacteremia and agrees to get a fistula placed. He gained autonomy, but he did lose time and safety. So the autonomy he gained does come at a price. And a second case, Mrs. J, she is 45. Her clinic insisted on a fistula before HHD. There are a lot of clinics that will require that you have a fistula because they don't want to train you on both a catheter and a fistula. And that is in some ways a defensible choice because we have a very limited access to HHD in this country. Retraining patients means taking away access to HHD to another patient who could be training in many places. So places may try to optimize in order to get access to HHD to as many as possible. And so this person, she CKD5, interested in home hemo, going to be an incident patient, but her clinic demands that she has a fistula. So that fistula took her 4 months to mature. That delayed her HHD start, which means that she was forced to start in center with a plan to transition home. You will find that forced to start in center with a plan to transition home, that plan doesn't often happen. And for her, that transition never happens. And so she had harm through lost opportunity. She never saw her preferred modality. And let's talk to patients. Here is a patient's perspective on fistulas or catheters from Kidney 360 in 2022. One patient said, I've been using a catheter for 4.5 years and I do home hemo. I'm on my second fistula attempt and honestly, I'm starting to think I'll just stick with a catheter. Fight for what you believe is best for you. We have to advocate for ourselves all the time. A clinician stated, I have plenty of home hemo patients who have catheters. I have plenty who decide not to seek out an AV fistula graft. They're aware of the risks and benefits. It's the patient's choice. It's their body, their disease, their treatment. Like I say to my patients, no one is more dedicated to preventing infection than the patients themselves. This is where we need to be. But our system has us in fistula first, and we need to move from fistula first to patient first, as described by the two patients in this perspective, or the patient and clinician in this perspective. And so we moved relatively quick to have some time to chat and also open up for any questions or discussion. But shared decision making really needs to involve more than just us, the patient, and the system. We need to inform, explore, align, and probably the other thing that I didn't talk about enough is revisit. Choices evolve over time. And so we need to evolve with the choices. We need to give patients the flexibility to change their mind, whether it's in dialysis modality and vascular access. We need to be thinking in terms of an ESKD life plan, which is where our guidelines have gone, just not where our quality metrics have gone. And so to conclude, I would say that the right choice is the one that aligns best with the patient's clinical reality and personal values. And I would also say, I hope that I will be seeing a bunch of y'all at ADC in a few months. And from there, I will open up to some discussion with our other panelists. So we have Dr. Alshami and Dr. Yaram on. I'm just curious what your experience is with catheters in home hemo, and what your experience has been with, I guess, executives and quality metrics and catheters in home hemo.
So I tend to be a fan of using catheters in home hemodialysis, especially if it's going to be an obstacle for patients to take on the modality. I use it as a way to encourage patients as, this is their alternative for PD, no needles, no blood, right? That's like visibly, there for them. Of course, you're going to see it in the circuit, but if this is the only thing that's standing in your way of choosing home hemodialysis, which is fear of cannulation, then I tend to not bat an eye when making that choice for helping facilitating it for the patients. And then we just re-emphasize the importance of clean catheters. We talk about the higher risk for infection, but we just keep reteaching, making sure that catheter exit site care is optimal for these patients. But absolutely, I agree with you 100%. Ideally, AV access would be great for the patients, but we also know that there's a high percentage of them, relatively speaking, that you have primary failure rates. So it's just something to consider. But absolutely.
I agree, and great presentation, Ankur, and you hit on all the major issues that we deal with on a day-to-day basis when we have these kind of discussions. And as Osama was saying, I think it's patients take better care, I feel like, and definitely lower risk of infections when patients use catheters at home. Because like you said, there is one operator, they know their catheters, they are the only ones accessing it. And most of these patients, once they're doing it day in and day out, they get better at doing it than some of the nurses early on in their training even, right? So we have seen that, especially like PD patients. A lot of times we see our PD patients complaining to us, oh, that nurse did not do this right, or they didn't do the dressing change or the cleaning or whatever. So the same thing applies to our home patients. So I think we need to give them credit. And also trust that they are the best advocates for themselves, because you're already, I think, screening out the patients that are motivated enough to want to do home dialysis. So these are the subset of patients that are already willing to put in the extra work, and so I think they usually do excel regardless of what kind of access they have. Granted, again, if they can get a fistula, yes, that's awesome, because that's the gold standard. But that doesn't always work out, especially in our area. For example, we have a lot of issues with the primary failure rate, or surgeon issues, turnover of surgeons and all of that. So personally, I think I would encourage patients that want to go with catheters at home. But again, the issue that you brought up in terms of physical discomfort, that's not trivial, right? These dialysis units, they have to deal with that, and there are severe penalties. And like you said, it doesn't just affect that one patient, it applies to the entire Medicare patients that you have. So I think it's important to change policy from that perspective, because everything follows money, right? Show me the money. So I think we need to advocate for patient first, as you've said, and try to make the policy kind of follow that.
Agreed. I think it's a well-intentioned and well-meaning policy, but I think it's a policy that has really, we've overwhelmed the system with saying that everyone needs to have the best outcomes possible, and the best outcomes really depend on the individual. If my parents went on dialysis, their goals of dialysis would be very different amongst the two of them. And so the right outcome to track is not the same. And so I think so we have a solution to a problem that maybe is now in a better place, and it's time for reform to give ourselves more flexibility for patients to be able to pursue their goals. Anyone in the audience have any questions?
And I want to say you can unmute yourself if you'd like and ask your questions. So go right ahead.
No, it's always a little awkward to put yourself out there. So feel free to throw it in the chat as well.
So, Ankur, I know you are heavily involved in the policy side. So is there any discussion about, changing, how we frame the access issue, or?
It's a good question. I think that there's a lot of discussions over kind of stagnation in the ESRD. Well, I shouldn't say ESRD because that includes transplant, but in the dialysis population, the thing that I always like to say is that the ESRD PPS and the bundle really optimized care around what dialysis was like in 2008 to 2011. And so I get to practice 2011 nephrology, but at the highest level. Like, I am the best 2011 nephrologist, but things haven't changed enough since then. And so I think that this is part of a system that needs reform. And you could say the whole quality system needs reform, because the quality system extends beyond QIP. We have QIP, we have 5-star, we have one other survey who's ICH CAPS. Yeah, we have 3 different quality systems with different metrics, sometimes different targets amongst the same metrics, some metrics that maybe aren't really nephrology metrics. We kind of have like quality, like qualititis or something. Like, we have a little bit too much in terms of quality right now. Even if you look at QIP, like if you look at the first few years of QIP, it was a much more narrow set of targets compared to what we have now. So I think that maybe even going upstream to what defines quality is probably a bigger question. But I think that there is a need to reform the system, but there's a lot of elements of the system that need reform. I'll put an example out there of difelikefalin, which has extremely, extremely low utilization, but half of the patients have itch. Like, when I round in dialysis, it is one of the most frequent complaints that I hear is that I'm itchy, or I don't even hear it. I just see someone in front of me, either with the excoriations or scratching, and I just say, "Are you itchy?" And they're like, "Yeah, I didn't say anything because I've been seeing you for 2 years and I've been itchy for the whole 2." So we have a bit of an innovation issue. And so I think there's probably a bigger need for reform to allow innovation to actually happen. And in allowing innovation to happen, that probably requires readdressing what quality looks like.
Yeah, absolutely. All right.
I'm really good at going off on tangents.
No, I mean, yeah, like I said, and some of these, metrics that are asked of dialysis units to be addressed, I think are at odds with the other metrics that are floated by, I don't know, like state metrics are different sometimes, CMS, all these, and that's so true on the transplant side of things for sure. And what they're trying to do on the dialysis side of things is really at odds with what they are expecting our transplant centers to do. So, there is not a lot of alignment, and that creates a lot of problems.
Totally. I was disappointed with the early I think that the evidence shows that the ETC model had not been effective, but I was curious what would have happened if there was some overlap between ETC and IOTA, if we had models in dialysis and transplant that were mandatory, that both that targeted dialysis units, nephrologists, and transplant centers to incentivize transplant. That would have been interesting to see, but probably would not have been enough actual time in those shared models to know if it meant anything. But you're right. We either go against each other and have transplant metrics that counter dialysis metrics, or we focus on half of the system and not the other half, and tell dialysis organizations and nephrologists that we're going to incentivize you to transplant patients, but don't actually target the transplant centers themselves. So we have some problems.
Yep, for sure. So I was curious. So what is the longest surviving catheter you had in a patient that, before needing replaced? And I was going to ask Osama as well, what his record setting.
So I will say mine is probably going to be the shortest of the group because we did not open our home hemo program until 2019, I believe. I always joke that part of the reason I moved to Rhode Island is when I was a second-year fellow, I went to Home Dialysis University, and they actually had a slide with the number of HHD patients in every state, and Rhode Island had one. And so I joked that if I started one patient, I could claim I doubled the state's HHD census, and now I can say I increased it 10,000+%. But probably the longest, I had a patient who he had 2 failed fistulas, had a catheter, and eventually was like, I am not going back to another fistula. I've been through surgery twice. He had primary failure on both. And he ended up dialyzing actually with the exact same catheter for 3 years, and then had some flow issues and ended up getting a catheter replacement, passed after 4 or 5 years of HHD with the catheter. But I didn't even realize that he had been using the same catheter for 3 years. But he had the exact same line for 3 years and did well.
Yeah, I think the longest one I've had was 7 years.
Wow, same catheter?
Wow.
Same catheter. I looked in now I haven't worked in one place for 7 years straight, so I can't take full credit for that. Hopefully this changes with the latest switch. But that patient has never had her catheter changed since it was inserted 7 years ago. And
oh my goodness.
That is incredible. But yes.
That is definitely incredible.
Yeah.
I think the longest I had seen was 3 something as well, and it started to break down, at the exit site, and so it had to be switched out. But there were no infection. So yeah, I think like you said, I think the patients on home hemo with catheters probably do better than the ones that go to the center in terms of infection risk and everything else.
And I think even if they don't, which I agree with you, I think that they probably do, but even if they don't, as long as that is their choice, they should be free to make that choice. It's
for sure.
If you have a malignancy, you get the choice of whether or not you want chemo or not. You get the choice of I want oral chemo or infusions, and you get to make the choice of saying, I don't want the most aggressive, but I'll take a moderate therapy. We do give people the choice of conservative care, but once you choose dialysis, your choices get limited pretty significantly by systems. And so I agree with you. I think that the differences will probably be favorable, but even if they aren't, I think it's still important that we continue to fight that doesn't limit patients from choice.
Right. And when you said it in the very beginning, it's very paternalistic of us to say, okay, you got to do this, but why should they if that's not fitting into their, lifestyle or anything else? So.
Agreed. But I think that 2% haircut doesn't sound like a lot, but it is. The most recent MedPAC report to Congress said that the marginal revenue for an additional in-center patient or home for with Medicare is 0 cents. So if your dialysis unit is making 0 cents off of a Medicare patient, minus 2% makes it a negative. And I think the HHD numbers are now 10 years out of date, but there was a CVO report that said that the marginal for adding an HHD patient was negative, actually. That's about 10 years old, and I would love to see something newer on that. But if you're out of pocket for adding an HHD patient, and they then make you even more out of pocket, that threatens your ability to provide dialysis to your entire cohort. So we have a system where even if you're viewing it from a very broad ethical perspective and from a perspective of choice, you could even argue that with the margins of Medicare and dialysis, giving one patient choice could be taking away choice from many others.
Very true.
We just need to fix the system.
It's a very complicated problem.
Yeah.
So I want to throw something that is not related to this, but since we're talking about paternalistic approaches, it's something that I've heard so many times from a lot of people, and I think it comes from a good place. But so you can probably tell my stance on it is not pro. But I've had multiple medical directors across the country say that for their in-center patients, they have mandated that all their patients be on 4 hours in-center HD. And that's the line. That's what everybody gets. And, it's kind of that's 4 hours and that's it. And the rationale that they use is that, the longer dialysis sessions, the better. This is what's best for the patients. And rather than sitting here arguing with the patients back and forth, we're just going to institute it as the unit policy under our care. So I kind of wanted to hear your thoughts on that. And if you're for that, all due respect, right, if that's what you do. But I kind of wanted to hear your thoughts on this for your in-center patients.
It's an interesting question. I'm going to respond kind of in lieu of what has happened with Fistula First, which is I struggle tremendously, even for patients who their primary objective is longevity, to get patients to 4 hours. There's a strong local culture of 3 to 3.5 hours. And so I would not complain if I could see a greater percentage of my patients who it was consistent with their long-term goals and moving to 4 hours. And so I almost wonder if I'm in the Fistula First era of dialysis duration, and if you might be in more of the patient first era where we fix the big problem and now let's get more back to flexibility. And so I might be a little bit in the minority there, because my biggest struggle every day is too little dialysis duration.
But these patients, they first of all, Ankur, you and I are only a year apart, man. But yeah,
no, I think just the location I'm in, like regionally.
I know, but we already struggle with these patients, getting them to complete their prescribed treatments, right? If we're having 3.5 hours, 3 hours.
I was going to say that also. Even if they prescribe 4 hours, what if the patient says, I'm not staying?
Yeah, like I can write for 6 hours. You know what I mean? Like the patient's going to be gone. You know what I mean? Like they're going to stay for as long as they want. But I get it that like your chances of hitting 4 hours are higher if your prescription is 4 hours, right? Compared to like, if your prescription is 3.5 hours, right? You're going to hit 3.5 hours, right? Like more so than you're going to hit 4, because nobody's going to stay, tell you, no, please keep me for an extra half an hour, right? So I get it, right? No patient's going to say that. But I mean, for me, like the argument of this is the policy of the unit, it's 4 hours and that's what we do. That is a little paternalistic though, because that's me telling you, like, this is what's best for you. This is what you're going to get. So it's kind of part of that struggle between, like, again, being patient-centric while also balancing the science. And that's an important balance, right? Because, again, and I say this a lot, if we're going to be patient-centric, if I tell my patients, you only need to do dialysis for half an hour, Preeti and Ankur, you'll have 0 patients. I'll have all your patients, right? Because they're like, there's this guy in Philadelphia who's doing half an hour dialysis, right? I'm going to go see him, right? But my patients won't be around for very long, right? It's your patients. So it's a fine balance, and I struggle with it.
Yes.
But yeah.
And in the final, and I think I was actually, this was the same discussion I was involved in during ASN. There were like a small group discussion. And there were, like, I think, questions about how long, because I think if you look at the data, USRDS data, the number of hours that HHD patients are dialyzing has steadily gone down over the years, right? So I think there was a question about, so how do you balance, the need to do more dialysis versus how the patients are doing and all of that. And some of the physicians were like, wow, I usually discuss the rationale with the patient, and, this is the reason you need to do, so many hours. But if the patient says, I don't want to do it, then, I'm not going to force them, was the reply from a couple of nephrologists. And then there was another one that said, no, that's not acceptable to me, because they were like, well, the consumer is not always right. I tell them this is what you need to do, and if they don't want it, then I can be their physician or something to that effect. And so I don't think I could personally say that, because Ankur, you were saying earlier, like if the patient understands the consequences, the implications of doing what they're doing, they have free agency, like you were saying, right? So
I think I also should update, because I think my answer was to the starting point being 4 hours, not the order staying at 4 hours. So I agree completely. Like, I don't think everyone should have the same prescription. And I think that the prescription,
especially with incremental dialysis, I think 4 hours is just kind of a moot point at this time.
Yeah. But I think what I would like is for the discussion to start around that range and then individualize to the patient. So I think when you said everyone is prescribed 4 hours, the concept that literally everyone is prescribed 4 hours, regardless of the amount of time that they actually want to do or would do, kind of just went right over my head. And so I actually am more on your side. I wish that the numbers were more close to 4 that we were oscillating around than 3.
Yeah. I mean, especially if there is an anuric patient, you really want them to do long.
Preeti, yeah. No. Don't let him do this. Don't backtrack now, man. You've picked your side. It's over.
No, I'm not backtracking, but I'm saying
no, not you, him. I'm talking about.
You wish, right? You wish, yes, yes, you wish the patients did that, but again, you're not going to be able to force them. Actually, I had a patient that was checking himself out 2 hours, after into dialysis, and he did this for months. There was another different medical director, and they were sending me emails saying, this patient you need to talk to your patient, you need to make them stay. And I'm like, I can't. And their numbers are okay. He's doing okay. He's still, peace, so I can't really, make them. And there is no good rationale for it. And even if, for example, his numbers are not looking great, and if the patient says, I refuse to come in for 3 treatments a week, or I don't want to stay 4 hours, I can't make them. How can I make them? So as long as he understands, right? That's kind of the key point. Yeah, so I just kept ignoring the medical director's emails, and then finally sent me a letter in the post, and this was a rural unit, and I'm like, I don't know, like what is the point of this?
Yeah, I mean, the discussion about I do appreciate the starting off with the 4 hours, right? That what Ankur said, because in HHD. Right, we try to do the same thing, because ideally we want the patients to do 5 days a week dialysis, and we talk about the benefits of doing 5 days a week, right, dialysis. So we try to make the starting point in the discussion 5 days a week. If you end up settling at 4, that's okay, right? But more patients are likely to take on the 5 days a week if that's what you're talking to them about in the beginning. So again, I am too teaming it, Ankur. Don't worry.
But also it defeats the purpose of home hemo if you do not do the amount of dialysis that is supposed to be beneficial for you, right? So
totally. And the way home hemo is being practiced right now is pretty different from all of the studies that we quote at conferences like ADC.
Right.
Those studies did not have 4 times a week. That is becoming much more prevalent.
Correct. Well, yeah, we have digressed, but there was this discussion.
Yeah.
All right. I don't know if anyone has any other questions or comments.
Well, thank you to everyone for joining us and entertaining the discussion. We hope to see you at ADC, and we will have another webinar. Oh, that was perfect timing, pulling up the abstract and case summary submissions. And registration is open.